So thank you so much. And I'm really honored to be speaking to this group today about something that has been a passion of mine for more than a decade. And I would like to dedicate this talk to Stevie, Elaine. It's a tragic story that we hear all too often. And also, I'd like to give a shout out to Dr. Andrew Kolodny, who was the chair of psychiatry here at Maimonides when I arrived. And I am so proud of the work that he's done in this incredibly important field. So everyone on this call is aware of the numbers, and they just get more appalling. We are getting dangerously close to 1 million American deaths since the late 1990s, and we've seen three waves, beginning with a rise in prescription opioid overdose deaths, followed by heroin, followed by synthetic opioids. And we know that between 3/5 and 4/5 of heroin or synthetic opioid users start with prescriptions from their doctor. We also know that there's a price for this and that the rate of opioid related deaths follows opioid sales in a linear fashion that one simply cannot deny. I love this slide because there's what we're seeing with every opioid overdose death is really the tip of the iceberg, where for every opioid death, we've got 15 to 20 abuse treatment admissions, just under 30 emergency room visits, another 115 people who abuse and are dependent, and another 700 non-medical users. The cost to the healthcare system, the cost to our country is incalculable. The rate of growth of opioid overdose deaths is really staggering. And going back to 1980 and looking up through 2018, again, the numbers are just completely staggering. Unfortunately, you're all aware on this call that COVID-19 has made a bad problem worse. And when we look at all of the sequelae of COVID-19, from social to financial to healthcare, we know that so many areas in my field of cancer surgery, we know that screenings effectively stopped in this country and in the United Kingdom in the first quarter of 2020. And the estimates are that we will see between 8 and 10,000 excess deaths just from colorectal and breast cancer because of the COVID-19 pandemic. This is so important as we look at opioid addiction and opioid abuse. In the first, if we look at the 12-month period ending in the summer of 2020, so half of that was the COVID first wave, there were 83,000 estimated deaths. That was up 25% from the same period a year ago, at which time the CDC reported 68,000 deaths. But many of us believe that the number is much higher. Many of us believe that the number is probably closer to 90,000 because of a systemic problem of underreporting and incomplete data reporting. Nora Volkow reported that the number of calls to the National Crisis Hotline run by the Substance Abuse and Mental Health Services Administration rose last year by more than 700%. And she's quoted as saying, during the pandemic, more people are experiencing anxiety, more people are experiencing depression, and one of the ways that people cope is by taking drugs. If you are addicted to opioids or to any drug, what you are seeing is an escalation, an increase in the consumption of drugs overall for people, whether you are addicted or not. We thought that the demise, at least the US demise of companies like Purdue Pharmaceuticals that had been using predatory business practices in promoting the distribution and sales of opioids would get better as the national spotlight was shined on this. There are institutions, Tufts University just announced that they were taking the Sackler name from one of its buildings. The Louvre is taking down the Sackler name over an Oriental art wing, but there are still a number of institutions shown here on this slide that have not yet sort of dealt with the Sackler problem. But we thought that when the spotlight was shined on Purdue and they were disassembled, that we would see a decrease in opioids. But of course, COVID prevented that from happening and actually very much made the opioid problem worse. So my question to my team about 7 or 8 years ago was, can we make a difference? If we tackle opioids on a patient by patient basis, can we actually make a difference as a single hospital in Brooklyn, New York? In my field of breast cancer, this was particularly important because simple mastectomy is among the highest surgeries associated with chronic opioid use, with a relative risk of almost 3. And you see this here with open cholecystectomy and total knee arthroplasty, which are the 3 highest procedures for chronic opioid use. We know that surgeons provide the majority of opioid prescriptions, and we also know that the majority of opioids that are prescribed go unused and unlocked and are all too often diverted. So there's a two-prong problem here of individual use dependency developing, but also of these opioids all too often falling into the wrong hands. There are 6 key steps that the Safe Communities Coordinated Response effort has focused on to stop the drug overdose epidemic. And I think surgery can actually tackle a third of these. I think 2 of these 6 can actually be dealt with from the perspective of the surgeon. I think who we are and where we are is important. With our LTAC and our skilled nursing facility next door, we are roughly 1,000-bed urban acute care hospital in southern Brooklyn. We have the 2nd highest population density in the United States behind Manhattan at 38,000 people per square mile. In calendar 2022, Brooklyn will surpass Chicago as the 3rd largest city in America. Brooklyn is a genetic, cultural, ethnic, and religious melting pot. Our patient bill of rights is in 46 languages, and we're busy. We delivered just over 9,000 babies last year under one roof. Our emergency department saw 140,000 patients, and we treated 6,000 patients during the first COVID wave. And as you'd expect, as a busy urban medical center in a very diverse area, we have a significant opioid abuse and addiction problem. Beginning in 2013, for 2 years, we began a major awareness campaign at our hospital to make a dent in inpatient opioid use. We had mandatory education programs for all levels of providers, from physician extenders, interns, residents, fellows, through chairman of departments. You couldn't prescribe opioids here without completing mandatory education. We revised electronic medical record order sets where it was all too easy to press a button and get 30 Percocets or 50 Percocets. And then we did close auditing and reporting back to the providers. I'm happy to report that by the middle of 2018, we could report a 40% reduction in opioid prescribing patterns by Department of Surgery on its inpatients. And you can see that this was true across all divisions, from general surgery to thoracic, trauma, vascular, and even pediatric trauma and pediatric surgery. The numbers were impressive. We went from just under 21,000 combined opioid orders to just over 13,000 opioid orders, simply by raising awareness, by auditing, by keeping score, and getting back to our providers. We then took this to my field, which is breast cancer. And this is a report that we gave to the Association of Women Surgeons at the end of 2019, just before the COVID epidemic hit. And what we looked at was mastectomy and the use of opioids in patients undergoing mastectomy. I do not own stock in Pacira or any of the companies we're going to talk about. It turns out I don't own stock in any successful American companies either. I have testified at no charge at the FDA on behalf of opioid-sparing regimens, including the use of liposomal bupivacaine. And the studies that I'm going to show you had no funding, either for design, implementation, analysis, or manuscript preparation. So we saw already that 130 Americans die every day from opioid overdose. That is more lives lost than we see from breast cancer. And we know that opioid naive patients, as most of our breast cancer patients are at increased risk for chronic opioid use after their surgery. We also know that acute postoperative pain predicts the development of chronic pain, and the risk of opioid use across a number of national cancer surgery studies is above 10%. And this number goes up if you need to undergo things like adjuvant cytotoxic chemotherapy. We also know that the likelihood of dependence after surgery is linearly associated with the days of opioids prescribed. And you see that in this graph on the right, where the the misuse rate per 100,000 process years goes up week by week with increased length of opioid prescriptions. The colorectal surgery world was the first to develop protocols under the name of enhanced recovery after surgery, and I will use that term a lot, ERAS. We took protocols that were specific to colon and rectal surgery, and we applied them to our breast cancer population. I'll go into a little bit of detail about these. We did a pilot study in patients undergoing breast conservation, smaller surgery, lumpectomy, and we found that using ERAS protocols and no opioids, zero opioids, that pain scores were equal or better than patients who were prescribed opioids at discharge. So here's what we do practically for the doctors on the call. So much of this is wrapped up in setting expectations. So in our pre-op visit, we stress the fact that we are going to control the pain without narcotics. You're not going to go home with an opioid prescription. And we reinforce this throughout the patient's journey through our cancer workup and cancer surgery. We do not believe in NPO past midnight, as was done for 100 years. In fact, we allow clear liquids up to 2 hours before surgery. We give both acetaminophen and gabapentin orally in the holding area. Intraoperatively, we pay attention to normothermia, euvolemia. We use an antiemetic protocol upon induction. And then we use liposomal bupivacaine, which I'll talk a little bit more about, as either a field block or a regional nerve block. And then we have both done this with and without ketorolac. We did publish a paper showing that there was not an increase in bleeding complications from ketorolac, but that really is left up to the discretion of the operating surgeon. One of the keys to this success of this has been liposomal bupivacaine, which is sold under the name Exparel. This is a remarkable nanotechnology product that has liposomes that actually contain bupivacaine. The liposomes burst at a very differential rate. which bathes the area injected in local anesthesia for 48 to 72 hours. And sometimes the pain control is even longer than that. And so for a mastectomy shown here on this cartoon, we are injecting the mastectomy flaps at their base with a mixture of bupivacaine, liposomal bupivacaine, and 0.5% bupivacaine. You can go down to 0.2%, 2.25% bupivacaine. You can also use normal sterile saline. Lidocaine will cause premature rupture of the liposomes, and so we cannot use lidocaine with this anesthetic mixture. And we have perfected this technique over a number of years. We stop IV fluids early, we advance diet early, we ambulate early, and then for postoperative pain, we use acetaminophen or ibuprofen. Patients are told they can call if they need a opioid, and they never do. So they're not sent home with an opioid prescription. I think that's really important. These patients undergoing big operations do not go home with a narcotic. There's an even mix between patients who are discharged on the day of surgery and patients who spend one night with us in the hospital. So we looked at our patients treated on this ERAS protocol, which is the data that I will show you. We collected the data. I'll be using the term OMEs, or oral morphine equivalents, to talk about the dose. These doses have been converted to oral morphine with cross tolerance adjusted for 0% reduction. We got post-op day 1 pain scores collected by nursing staff, and then on a number of post-operative visits, including collections of data by the surgeons. We also correlated our data with post-operative complications such as hematoma, infection, return to the ED. The number one reason that surgery patients return to the ED is pain control, not bleeding, not infection. And we also kept track of things like chronic seroma formation. So from September 17 to August 18, we did a pilot study of 153 patients, 57 of whom met inclusion criteria. We had a community surgeon who had not yet bought in to the ERAS protocol. Those patients served as the control group that I'm going to show you. And these groups were well matched regardless of race, age, insurance, comorbidities, and the other factors you see listed here. To summarize this table, you've got the ERAS group, the group that received the protocol that I went through. You can see that there was a mean inpatient oral morphine equivalence of 2.4% or 2 discharge OMEs in the ERAS group, compared to almost 60 OMEs in the usual care group, and this difference was statistically significant. When we look at pain scores, remarkably, the pain scores were better in the ERAS group. The ERAS group that did not receive opioids had less postoperative pain, and this was independent of whether you had a mastectomy with or without a sentinel node biopsy. And this difference in pain score was statistically significant. Remarkably, this remained true at 1 week, where we collected pain scores. And again, the mastectomy with or without sentinel node biopsy group treated with no opioids, essentially 0 opioids, had a statistically better pain score than patients who got a lot of opioids. We know that the opioid level we had been prescribing historically was almost invariably above the lethal dose if taken together in opioid naive humans. And you can see on this bar graph on the ERAS protocol, which is the darker bars, how much we were able to reduce discharge opioids. So we concluded that you didn't need opioids to do large cancer operations. The pain scores were significantly better in the ERAS group that did not receive opioids compared to the control. And to see a difference that's this striking in 60 patients is impressive. Normally, you would need a lot larger numbers to see a difference like this. We did not see complications being different, including bleeding between the groups. This was one of the first studies to show that you don't need opioids for mastectomy patients. We did have a few patients who crossed over to liposomal bupivacaine, but that was not the sole explanation for optimized pain control. We really believe that the multidisciplinary approach, from setting expectations to acetaminophen and gabapentin in the holding area, to normothermia, to rapid ambulation, we think everything matters. In my experience, probably nothing is more important than setting expectations, convincing patients that you don't need to go home with a prescription for opioids. So we felt that we had broken down our previous lax dispensing traditions and we rebuilt them from the ground up. Since then, when we look at both lumpectomy and mastectomy patients, we have eliminated over 80,000 oral morphine equivalents, which are not diverted in Brooklyn and are not causing addiction. We have now expanded these protocols to colorectal general joint replacement surgery, which we're doing as an outpatient now, both thoracic and cardiac surgery, reconstructive surgery. We're using this for deliveries and GYN procedures, and of course, for spine surgery. Now, we've learned a few things along the way. Obese patients are at a greater risk for opioid dependence, and we have a patient population that tends to have a higher than average body mass index. And so we did a pilot study looking at lumpectomy in 1,357 patients, where one of our focuses was body mass index. Except for BMI, these groups were well balanced. There was a relative and absolute reduction in risk of pain that was greater in the non-obese patient when compared to the obese patient. We saw something similar 15 or 20 years ago when we were scheduling dosages for chemotherapy, where using ideal body weight was not the best way to calculate the doses for chemotherapy. We also saw that the higher body mass index group had dramatically higher pain scores 1 week after surgery. And our conclusion was that high body mass index patients actually benefited less from ERAS, which meant that we had to change our ERAS protocol. And I won't spend time on the data. The bottom graphs show that while the lower BMI patients' pain actually got better with time, which is what you'd expect from surgery, in the higher BMI patients, the pain actually got worse with time. So looking back at both of these, it's actually 3 different studies. We've now gone over 100,000 oral morphine equivalents that we have completely eliminated from the care of breast cancer patients. And it's something that we're quite proud of. Now, I'll finish with this thought. In the oncology world, it's not just about protecting our patients from opioid addiction, and it's not just about preventing diversion. There is growing evidence that the receptors that are used with opioids are also players in cancer signal transduction pathways. And so the question that's out there is, can opioids actually worsen cancer prognosis? And we know that opioids are capable of impairing our immune response. In March of 2018, we approved the first immunotherapy for breast cancer. Atezolizumab was approved for advanced triple negative breast cancers. implying that our immune system still plays an important role in our fight against cancer. We know that opioids increase new blood vessel growth or angiogenesis. We know that opioids are capable of decreasing the effectiveness of both natural killer cells and T cells. And there's evidence that opioids may directly act on tumor cells, promoting both growth and metastases. And I won't go through all of the data here, other than to say that both animal and human and laboratory-based cell culture studies all continue to come to the same conclusion, that opioid-induced tumor growth is real, and that direct stimulation of the mu receptor plays a role in cancer signal transduction. There have been several large studies. This was a study of 42,000 patients undergoing colon cancer surgery, and this was an ERAS protocol study. And lo and behold, and maybe not surprisingly, the ERAS group in whom opioids were eliminated or reduced had a longer survival, a longer colon cancer specific survival than patients who received conventional opioids. So this is still a story in evolution, and studies are going on to look at this. But in our patients, I might argue, why take the chance? If we have an alternative to opioids, why take the chance that the opioids are worsening survival? So this is what, up until the beginning of COVID, this was what our decrease in oral morphine equivalents looks like over time. Here's a line graph that shows it. This was completely cost neutral to the hospital, and we can talk more about that. So in conclusion, the COVID-19 pandemic undoubtedly will cast a long and dark shadow over a variety of things, from medical, societal factors, financial factors, educational. But it's an absolute fact that COVID-19 worsened our opioid crisis considerably. We have worked hard to reduce opioids from one of the most common cancer operations in the country. Opioids may worsen outcomes. I would argue that this is relatively straightforward to implement. There's a huge cost benefit. This is not an expensive program. If we could get even 10% of the hospitals in America to adopt an ERAS protocol for breast cancer, where there are more than 400,000 operations a year done just on the breast cancer itself, and probably another 1 million operations done on breast cancer related factors, imagine the impact that would have on this country's opioid crisis. So I think with that, I'd like to stop, and thank you very much for your attention, and I would be happy to take any questions.
All right, thanks so much, Doctor. One question that we had, if you could talk a little bit about how anti-anxiety medications impact or have an influence on what you've discussed.
Yeah, I might even throw that question to Dr. Kolodny if he's on. I know that he has looked at this. I don't know if Andrew has.
He is on, but we're unable to let the attendees. Yes, but we can definitely then.
Yeah, I mean, we have not.
You can speak to. We can follow up.
Yeah, I mean, I can tell you that. So first of all, independent of the opioid question, there's very little that is as stressful as being told you have breast cancer. And so we have both a cancer trained psychiatrist and psychologist at our cancer center, and they play an extremely important role in helping our patients bridge the time period between diagnosis and treatment. And one of the things that's unique about Brooklyn is the number of young patients that we have, truly young patients with breast cancer. And for most of them, they're facing their mortality for the first time. And so I do think there's a role for support and for anti-anxiety medications. We have not yet rolled that important question into the ERAS question, but I really look forward to that study.
All right, thanks. And we'll share some any other resources and additional information with all of you attendees post-event, and we'll have information on the website as well to expand on that. Doctor, we have another question. How does a hospital achieve being cost neutral by not using opioids?
So if you look back at the protocol that we talked about, the only real cost that is additive to the entire cancer trajectory is the liposomal bupivacaine, which comes in 2 doses, either a 10 milliliter or a 20 milliliter. And using ballpark numbers, the 20 milliliter is just under, I believe, $300, and the 10 millimeter is half that. So that is a cost that we had to get our hospital to approve. When you look at things like reduced time in the recovery room, faster trajectory recovering from surgery without opioids, when you look at patients being discharged home rather than being admitted, when you look at a decrease in emergency room visits for pain control, the numbers come out overwhelmingly favorable as a return on investment. So Dr. Kolodny will tell you, we're not a wealthy hospital. We have about 85% of our patients are government pay. We also have a very large subset of under and uninsured patients that we take care of. And yet we were able to show a return on investment financially for this program.
All right, great. And I think that, could you talk about what the underlying reason that obesity being a higher risk for pain in your patients? Could you talk a little bit about that?
Sure. I don't think we know all the answers. I think that, what we saw with cytotoxic chemotherapy was that we were underdosing patients because we were using ideal body weight. By switching to things like body surface area, we've been able to more correctly dose patients. I think that's analogous to what we will find as we look at acetaminophen, as we look at gabapentin, as we look at the volume of liposomal bupivacaine and as field blocks. I think that it's likely that we have been under treating them. So we're looking at this now. We have in collaboration with a couple of our teams, including our bariatric surgery team, we are looking at evolving ERAS protocols based on body mass index. So hopefully in the next 6 months, we'll have an answer to that.
All right, great, thank you. And I think we're coming to the end. I don't know if there's any other questions. Oh, we have one more. Are there any recent studies that showed that Exparel was better than regular bupivacaine?
Sure. That was the very first study that we did. Exparel is a time-released liposomal encased bupivacaine, and because of the manufacturing process, the liposomes break at a different rate, and so you actually have measurable bupivacaine in the wound 48 to 72 hours later. Not true with regular bupivacaine. We've all used lidocaine, we've all used bupivacaine in our practices for the immediate postoperative pain. By the time the patient gets to their hospital bed or their home, those effects have worn off. And so I don't think that liposomal bupivacaine is the whole story, but I think that this would be difficult to achieve without it. as I travel around the country meeting with my colleagues and talking about this, so many hospitals decide not to pay for the Exparel. And I understand that. These are very tough financial times, but it's actually really very straightforward to do the return on investment calculation, where all of a sudden that $150 for 10 mLs of liposome bupivacaine just becomes the best investment you could possibly make.
All right, great. Thank you so much. And Doctor, just one final question. As you know, the Opioid Education Foundation is really dedicated to getting the cultural change that patients receive information about the risk of opioids from their prescriber. Can you talk a little bit about why that is important and why it's important to have these conversations about alternatives, or to have these protocols about alternatives that you so wonderfully presented on today?
Sure. I couldn't agree with you more. And so you can imagine that breast cancer runs in families. And so a daughter might remember the pain that her mother suffered when she had her mastectomy 15 years ago, and how the mom went home with a big jar full of opioids, and she took them every 3 hours to be comfortable. And what we have to do is change the expectation of the need for opioids. And sometimes that means, for someone that pushes back or says, no, I don't want to be in pain, sometimes we will really go into some detail about what the risks are, exactly what you're talking about. This is why we're not using opioids. And sometimes it's quite a deep dive into the risks of the opioids that your foundation is so importantly, touting, because the risks are real. And so I would say that maybe 15% of the time or 20% of the time, we do a deep dive with the patient on why pain is bad and opioids are bad, and we're gonna get rid of both.
All right, thank you so much. Appreciate your presentation. It was so comprehensive. We're going to be able to share this information with all of our attendees today. So everyone who is on will receive a link to this presentation that you can review, and there'll be also information on how you can receive continuing medical education credit and additional resources for safe prescribing, and about the patient notification laws, both at the state level and in Congress. So we'll be sharing all of that information via email with all of our attendees today by tomorrow. Again, Doctor, thank you so much for being with us. Thank you for sharing this information, and thank you for all the work that you're doing in really exploring alternatives to opioids. So thank you again, and
My
have
honor.
a good day.
Thank you so much, everybody.
All right.
Thank you.